Welcome to our video on benign dermatologic conditions. Let's get started. Here's our overview slide. Let's begin by discussing lichen simplex chronicus. With regards to this topic, we'll be discussing general characteristics, clinical features, diagnosis, and treatment. Let's begin with some general characteristics. Lichen simplex chronicus is a dermatologic condition secondary to chronic irritation. The chronic irritation leads to lichenification, which is a leathery thickening of the skin due to epidermal hypertrophy and hyperplasia of the vulvar epithelium. Typically, lichen simplex chronicus is the result of a chronic scratchy itch cycle. The patient has some initial irritant, which leads to scratching of the area. The scratching leads to irritation and thickening of the skin, which then leads to more itching. This cycle then repeats itself, and the skin becomes more and more hypertrophied. Even though there is hypertrophy and hyperplasia of the skin in lichen simplex chronicus, there is no increased risk of squamous cell carcinoma. On physical exam, you may see excoriations and epidermal thickening. The lichenification of the area also leads to accentuation of the skin markings. The area may also be erythematous with hyperpigmented plaques secondary to chronic irritation. The diagnosis is based on the history and physical exam. Biopsy is not required unless a lesion persists for greater than 3 months without treatment. If this occurs, it should be investigated further with biopsy to ensure that the lesion is not a potential cancer. Here is a histological image of lichen simplex chronicus. At the top of the image, you can see hyperkeratosis, which is associated with lichen simplex chronicus. In this top layer of the stratum corneum, you can also see retained nuclei, which is called parakeratosis. This is another characteristic finding of lichen simplex chronicus. Finally, you can see thickening of the epidermis, which is known as acanthosis. The treatment first involves removing any irritants that could be contributing to the scratch-itch cycle. Oral antihistamines can be prescribed in order to minimize the itching and in turn decrease the amount of scratching. Topical steroids can also help decrease inflammation and irritation in the area. In addition to the medications, the patient should be advised about good vulvar and vaginal hygiene practices. They should be instructed to wear loose-fitting clothing and underwear, preferably made of cotton. They should also avoid using scented soaps, bubble baths, feminine sprays, and douching because all of these can lead to irritation of the skin. All right, let's try a question. A 25-year-old woman comes to the physician reporting vulvar irritation and itching. She is a dancer and frequently has to wear thick, tight polyester costumes. She enjoys taking bubble baths with scented soap at the end of the day. The physical exam reveals a thickened and lichenified vulva with multiple scratch marks. Topical application of which medication is most likely to resolve this patient's condition? All right, this patient presents with vulvar irritation, itching, thickening, and lichenification. Given her history of wearing thick, tight costumes and taking bubble baths with scented soap, this presentation is most consistent with the diagnosis of lichen simplex chronicus. Topical application of corticosteroids has shown to be beneficial for patients with this condition. Okay, now let's move on to discuss lichen sclerosus. This is an inflammatory dermatosis with an unclear etiology. Some familial association has been noted, but there is no clear genetic predisposition or inheritance pattern. This condition can occur at any stage, but it's most commonly seen in postmenopausal women. Unlike lichen simplex chronicus, lichen sclerosus is associated with an increased risk of developing squamous cell carcinoma. On physical exam, lichen sclerosus will appear as well-demarcated thin skin. It can involve any part of the genital area, including the vulva, labia majora or minora, clitoral and preclitoral skin, and the perineum. When lichen sclerosus involves the vaginal area, perineum, and anus, it's sometimes described as a figure of 8 pattern. Lichen sclerosus is associated with symptoms such as pruritus, dyspareunia, bleeding with minimal trauma, and painful defecation secondary to the skin damage associated with the disease. Atrophy of the areas affected can eventually lead to labial fusion, contracture of the vaginal introitus, and fragility of the skin. In this image, we can see the characteristic findings of lichen sclerosus. A sclerotic white plaque can be seen in the middle of the image, covering some areas of the clitoral hood and labia minora right here. And surrounding this area of sclerosis, there is also a visible edge of erythema and inflammation, which we can see right here. The diagnosis is primarily based on the history and physical exam. However, a punch biopsy should also be obtained in order to rule out carcinoma. Histological findings of lichen sclerosus include chronic inflammatory cells, thinning of the epithelium, sclerosis of the dermis, and loss of the reti pegs. In this image, the histological findings of lichen sclerosus can be seen. At the top of the image, we can see hyperkeratosis that's associated with lichen sclerosus. Below this, we can see that the dermis has thinned and there's loss of reti pegs. Additionally, areas of an inflammatory cell infiltrate can be seen in the dermis. The first-line treatment is a high-dose topical corticosteroid such as clobetasol, followed by maintenance topical steroids. Even with first-line treatment, lichen sclerosus often persists as a chronic condition. Other potential treatments include topical tretinoin and pimecrolimus. All right, let's try another question. A 70-year-old woman comes to the physician due to vulvar itching. She has also noticed pain during defecation for the last 6 months. Her last menstrual period was 20 years ago. The physical exam shows thin white skin around the vaginal introitus and the anus. Biopsy of the lesion reveals dermal fibrosis and epidermal atrophy with loss of the epidermal ridges. How does this patient's condition differ from lichen simplex chronicus? All right, this patient presents with vulvar itching, dyschezia, and thin white skin around the vaginal introitus and the anus. This presentation is consistent with the diagnosis of lichen sclerosus. And let's compare lichen sclerosus to lichen simplex chronicus. Lichen sclerosus is the disease of postmenopausal and prepubertal women, while lichen simplex chronicus can occur at any age. Secondly, lichen sclerosus is characterized by thin white skin, epidermal atrophy, and dermal fibrosis, while lichen simplex chronicus is characterized by thick skin with epidermal hyperplasia. Finally, lichen sclerosus increases the risk of vulvar squamous cell carcinoma, while lichen simplex chronicus does not. Okay, let's move on to the last topic, lichen planus. Lichen planus is a dermatologic condition that can affect the vulvar area and other areas of the body. It's often associated with autoimmune diseases and HCV infection and typically occurs in patients greater than 50 years of age. It can also be associated with medications that cause a lichenoid drug reaction, such as beta blockers and thiazide diuretics. However, it's important to note that while these lesions appear similar to lichen planus on physical examination, they're not histologically identical. Lichen planus is also associated with an increased risk for skin cancer of the vulva. On physical exam, it will appear as shiny purple papules with white striae. The white striae can also be described as a lacy appearance. In addition to the purple papules, there may also be desquamative ulcers. All of these skin changes can lead to pruritus, burning, dyspareunia, and vaginal discharge. They can also lead to vaginal adhesions and erosive vaginitis. If a patient presents with lichen planus in the genital area, they may also have lichen planus in other locations, such as their oral mucosa or extremities. You may hear the clinical features of lichen planus summarized as the P's of lichen planus: pruritic, polygonal, plantar, purple papules, and plaques. In this image, you can see the clinical findings of lichen planus of the oral mucosa. As I mentioned earlier, patients with lichen planus in the genital area will often present with lichen planus in other locations. The most obvious feature of lichen planus in this image is Wickham striae. These are the lace-like white lesions that can be easily seen in contrast to the red oral mucosa. Like all of the other benign dermatologic conditions of the vulva and vagina, lichen planus is primarily diagnosed with a history and physical exam. However, if one decides to biopsy a lesion, the histology will show hyperkeratosis with basal layer destruction and a lymphocytic infiltrate at the dermal-epidermal junction. In this image, we can appreciate some of the histopathological findings of lichen planus. At the top of the image, you can see hyperkeratosis. You can also see a prominent lymphocytic infiltrate at the dermal-epidermal junction. And finally, there is destruction of the basal layer, which is also characteristic of lichen planus. The treatment involves prescribing topical steroids and vaginal steroid suppositories if there are any lesions present inside the vagina. If the patient is on any medications that are associated with a lichenoid drug eruption, they should be discontinued. Here is a summary table, which should be helpful in reviewing the information of this lecture. All right, let's wrap up with a final question. A 57-year-old woman comes to the physician due to severe vaginal itching. She has noticed purple lesions on her vulva for the last 10 months that have progressively worsened. She has a past medical history of congestive heart failure and knee osteoarthritis. The patient takes metoprolol and occasional acetaminophen for her medical conditions. The physical exam reveals purple papules and plaques on the vulva and white reticular lesions on her buccal mucosa. She is hepatitis C negative. Which medication is most likely associated with this patient's current condition? All right, this patient presents with pruritic purple papules and plaques on her vulva and white reticular lesions on her buccal mucosa. This presentation is most consistent with lichen planus. This patient is hep C negative, making infection-induced lichen planus unlikely. Lichen planus can also be associated with certain medications such as beta blockers and thiazide diuretics. This patient is taking metoprolol for her congestive heart failure. And recall that this is a beta blocker, so this is the most likely cause of lichen planus in this patient. So the answer to the question is metoprolol. And that concludes our lecture on benign dermatologic conditions.